Before we move into the third phase of pharmacokinetics, which is metabolism, there is one other thought about distribution that I need to mention. The drugs in the body often have barriers to distribution, and one of those barriers is the blood-brain barrier, and the other is the blood-placental barrier. One of our adaptive compensatory mechanisms in our body is that our blood-brain barrier protects our brain, our higher centers that determine and control our function, from chemicals that could cause harm. So very few categories of drugs can cross the blood-brain barrier. Drugs that do cross the blood-brain barrier are considered to be sedatives, anti-anxiety agents, anticonvulsants for seizures. These are drugs that do cross the blood-brain barrier and are prescribed to help with disorders in the central nervous system. Chemotherapy, for example, is a category of drugs that does not cross the blood-brain barrier. So this is a good thing in that the brain is spared some of the destructive effects of the chemotherapy drugs used for cancer. The negative of this mechanism is that the cancers in the brain, if they're primary tumors or metastatic lesions to the brain, will not be helped by chemotherapy that is used in the bloodstream. So we need to think about other ways to treat problems of the brain if the chemicals in the drugs are not able to reach them due to the blood-brain protective mechanism. Additionally, when babies, our fetuses, are growing in utero, the placenta has a placenta blood barrier that protects some chemicals from reaching the developing fetus. Certainly, when you get into your maternity rotation, you will learn about which drugs pass the blood placental barrier and need to be used in caution, and which drugs do not pass through this barrier when mom is pregnant. Now, the third phase of pharmacokinetics is metabolism. Metabolism is the process by which drug chemicals are broken down, degraded, and put into a process of inactivity. The liver is the primary organ that is responsible for metabolism. There are a few other ways that some drugs partially are metabolized that we'll look at, but what you should think of when you hear the word metabolism is liver. Therefore, if the liver is not healthy, metabolism could be affected. If metabolism is affected in the direction that chemicals are not broken down and degraded, that means that the chemical stays active in the body for longer, which can lead to levels of toxicity of that drug. The hepatic microsomal enzyme system, the P450 system, is the primary enzymatic system in the liver that inactivates drugs via metabolism. One other aspect to consider is that there is potentially a drug-drug interaction, or drug-food interaction, or drug-beverage interaction, or drug-herbal interaction that can occur at the level of metabolism. So again, when you read about drugs, you want to appreciate, are there any drug-chemical interactions that need to be thought about in regards to metabolism? The term prodrug is used to speak about drugs that must first be partially metabolized by the liver in order to be in an active state that the body tissues can utilize in a therapeutic way. Often prodrugs are drugs that take longer for the effect to be seen because of this need to go through partial metabolism first. Situations where health can play a role in metabolism need to be critically considered. Obviously, if somebody has primary liver failure due to hepatitis or liver cancer, for example, we would know that that liver is not functioning well. A liver that is not functioning well is at risk for not metabolizing drugs as it should. Again, when drugs are not metabolized as they should be, active drugs stay in the system longer, which can lead to toxicity of that drug in that individual. For the most part, if we think about the age continuum, we consider the very young infants as well as the elderly to have potential deficits in liver function. We know in infants that are newly born that their livers are not 100% functioning, and that it takes over the first year of life for those livers to function properly. So in regards to drug therapy, often very small doses of drugs are given, recognizing that metabolism is not going to be as efficient as it needs to be in small infants. Similarly, as we age, we have body systems that start to fail us just because they've been running for a lifetime. So just like a well-used car, our bodies start to run out of function as we age. So we often think of the elderly of being at risk of having some level of decreased liver function, therefore at risk for some level of decreased metabolism, therefore at risk for increased risk of toxicity from a drug. We certainly can monitor liver function via a blood test. A blood sample can be drawn and sent to the lab, and we can monitor for what we call LFTs, liver function tests. And we look at some enzymes, ALTs, ASTs, and alkaline phosphatase, which are three enzymes that directly measure the function of one's liver. So if somebody has decrease in their liver function tests, then we would know that most likely the dose of drugs are going to be decreased, and we're going to be monitoring very closely for any signs and symptoms of a toxic level of that drug in the body. Another phenomenon that can impact the pharmacokinetic process of metabolism is called the first pass effect of a drug. Again, this is something that is very arbitrary and is very individual to that particular chemical in that particular patient's body. And what it describes is a situation where drugs that are enterally administered, so it has to be an enterally administered drug, gets absorbed directly into the liver circulation before body circulation. When that happens, metabolism occurs before distribution occurs, which means that less drug is sent into general circulation, so less drug reaches the target tissues, so there is less or subtherapeutic effect from that chemical. We never know if first pass effect is occurring, so it's something we just assess and monitor for. It generally occurs in a situation where a patient is not having a therapeutic effect. The dose is increased a little, patient is still not having a therapeutic effect, and again, we consider that because the drug is administered enterally or orally, that it might be going through the first pass effect in the liver, where metabolism is happening before it goes into general circulation. The only way to fix this situation is to give a different or alternate route of delivery. So give the medication topically or parenterally and avoid the enteral route of that drug. The fourth phase of pharmacokinetics is called excretion, and excretion relates to the way that drugs are removed by the body, and specifically drugs that have already been metabolized. So inactive byproducts of metabolism are removed via excretion. Just like the infants and the elderly might have insufficient liver function, they might also have insufficient kidney function. We know that infants in their first year of life are developing their kidney function, so they are at risk for not excreting properly. So oftentimes doses will be adjusted in small infants. Additionally, as we age, our kidney system can become less functioning. So if the person has a less functioning kidney, the drug chemicals that have been inactivated partially are not going to be properly excreted, and they can be kicked back in general circulation. And partially inactive drugs still have some activity, so patients might exhibit a toxic effect when the kidney function is not 100%. Obviously, if somebody is diagnosed with acute or chronic renal failure, then the excretion of the drug is going to be affected, and that leaves active or partially active drugs still circulating, and we can see toxic effects from that drug. So I guess the moral of the story in regards to metabolism and excretion is if there is any decrease in liver function or decrease in kidney function, then we need to monitor very closely for signs and symptoms of toxicity from that drug, as well as recognize that the doctors are probably going to prescribe a less dose of that drug. Ways that we can monitor for kidney function relate to the intake and output of fluids into the body. So what fluids go into the body should equal the amount of fluids coming out of the body in the form of urine. So when output is less than input, we would start to worry that excretion or kidney function is not being as efficient as it should be. Additionally, we can look in the bloodstream at two blood draws. One is called the blood urea nitrogen, or BUN, and the other is called the creatinine. And both the blood urea nitrogen and creatinine lab value show us some ideas as to how functioning or dysfunctioning the kidney is. And again, we would relate that to the dose of drug and the need to monitor for toxic signs and symptoms of that drug in the body. The kidney, as we said, is the primary excretory organ for chemicals in the body. However, there are some other body systems that can allow for excretion that we will talk about. Before we do that, I do want to mention the drug protein complexes that we talked about earlier in a different pharmacokinetic process, specifically the distribution. So when a drug has a high affinity to attach to a protein, that complex is unable to be distributed. So it doesn't reach a target organ and it doesn't have a therapeutic effect. Additionally, this drug protein complex is unable to be metabolized and it's unable to be excreted. So it stays in the system and gets recirculated, and at some point in time, the drug will separate from the protein albumin and become active. So it's something also to consider when we think about the excretory phase of the process. Excretion is affected by the pH in the urine, and this is important when we consider remedies or antidotes to overdoses. So for example, if somebody were to take an overdose of aspirin, aspirin is a highly acidic drug. So the way that the doctors will try to encourage the excretion of the toxic aspirin levels is to make the urine more basic with something like sodium bicarbonate. Additionally, if the patient overdoses on a drug like Valium, which is a highly basic drug in makeup, they would use a chemical that is more acidic to change and alter the pH of the urine to encourage excretion. So kidney is the primary organ of excretion. However, as I stated earlier, there are some other organs that can play a role in excretion. In a small way, in some drug categories, the drug is excreted in part via the saliva. So when a patient says, oh, I taste a metal taste in my mouth after you gave me that drug, it is because part of that drug has been excreted in saliva, creating a metallic taste in the mouth. Other drugs are partially excreted via the sweat glands, and a good example of this is garlic. Garlic is a chemical that is partially excreted via the sweat. So next time you or your friend or family member eat a lot of garlic, work up a sweat, and when you smell the odor of the sweat, it will be highly garlic in nature.